Good afternoon on this splendid day, or at least it is here. I hope it is where you are too, with regards to the weather. I know we're all into week, whatever it is, of lockdown. I've stopped counting, which is better for my mental health. Also better for my mental health is this webcast. We're going to be talking about after the peak, well, the rapid innovation of IT in the NHS outlast COVID-19. So pretty topical as to the situation we're all in. If that's not your intention, if that's not what you thought you were going to be watching this afternoon, then something's gone wrong. But that's what we are going to be discussing. And thankfully, rather than listening to my inane ramblings, we have three very good and prominent panelists to be able to discuss this topic with us this afternoon, who I'm going to ask to introduce themselves, if I can, in turn, and then we can go straight into it. So if I could ask, just because the order it's showing on my screen currently, if I could ask Nicola Raymond to introduce herself, please.
Hi, so Nikki Raymond, I hate being called Nicola.
Noted.
I'm Head of Digital Services down here in sunny Cornwall for Cornwall Partnership Foundation Trust. So we are a community mental health and adult community trust covering the whole of Cornwall and the Isles of Scilly. So although I head up the team here, we work very closely with our colleagues in Royal Cornwall Hospitals who deliver the only acute care in Cornwall.
Thank you, Nikki. I did write Nikki and circled it and then completely forgot about it and read straight off the screen. So you would have thought I've got used to this sort of stuff by now, considering we're in week whatever, but there we are. Adrian, I think I'm safe. Adrian Byrne, if you'd like to introduce yourself.
Yeah, sure. Adrian Byrne. I'm the CIO at University Hospital Southampton, teaching hospital, South Coast, large hospital. Obviously, it's a different place in these times. Weird, really.
Yeah.
On the one hand, it feels very quiet, but on the other hand, there's some crazy stuff going on, obviously. I also chair the National CIO Network with Digital Health, so that's another part of what I do.
Brilliant. I'm sure we'll come on to that. And Philippa.
Hi, I'm Philippa Winter, CIO at Bolton Foundation Trust. Bolton is an acute and community organisation with about 8,500 staff. Obviously a big general hospital, second busiest A&E in Greater Manchester, and obviously a large footprint with the community services. But also incidentally I provide IT services to primary care and the CCG.
Thank you. Thank you all for your time today. In the interest of time as well, if anyone's watching, listening, if they'd like to ask any questions, if they'd like to put that in the chat, we'll try and answer as many questions as we can if we have time towards the end. We're looking to speak and discuss for half an hour, maybe 45 minutes, depending, and then and have some questions involved in that as well. The first thing I'd like to do, so I'm very interested in where technology and society meet, but I'm not a healthcare professional by any stretch of the imagination, or even involved. Can I just check the hypothesis? I hear a lot that because of the coronavirus, because of COVID-19, there's been an acceleration in the adoption of digital, and digital's done amazing things. Can we just check that first with each of you to say whether or not that is the case, and that has been your experience, that actually COVID-19 has accelerated the adoption of digital and the pace of change? Anyone could go. Nikki, do you want to go?
Yeah, sure. Absolutely. I would say, I guess the term I've been using is around digital embracement, whereas before it seemed a bit of a challenge sometimes to get people to adopt the technology. Certainly over the last 6 weeks, we've just seen people screaming for the technology. So I think, yeah, certainly a shift change, particularly around mental health services for us, and doing an online delivery.
Okay, what does that look like then, sort of the digital adoption in mental health care provision?
So traditionally, our mental health care was very much going out to see the patient in a home setting or another location, and all of that is now shifted to being the use of video or telephone appointment. And we had no video appointment capability before at all, so we've literally gone from 0 to last week just under 500 video appointments for mental health services. So a real shift change.
Yeah, 0 to 500, that's significant. Adrian, what's been your experience or observation?
I think a mixture of factors. Nicky's just referred to one really about there's a level of interest in what we do now that probably wasn't there before, and that's born out of necessity really. So you've definitely got the ear of people you might have found quite difficult to get the ear of before. I think that's been helpful. I think investment is, it's talked about a lot in terms of what we do, the fact that this country doesn't actually put enough money into digital and sort of what we do in the health service. So there's been an injection short term that's tempered with some supply issues. Obviously, it's been quite hard to get hold of things, but there's been an injection of cash, which has helped us. And in terms of acceleration, what most people see is an acceleration of using things that were used in a fairly small and piecemeal way. So things like working at home. We probably had 100 people working at home on a busy day, and we're now talking about thousands. So we've had to ramp up those kind of things and roll out a lot of laptops. We've doubled our laptop estate. So, and that's just boring stuff, and that's just buying sort of computers and sticking them on the network. And why wouldn't that work? You buy more of them, it should work.
Yeah.
There's also been a requirement to develop fixes for things, unforeseen problems. We've had to manage cancellations of large numbers of outpatients, or well, hopefully not cancel them, but hopefully convert them into telephones or video. And we've had to develop systems to manage that so that people don't just fall down a hole and get forgotten about. So there's been some basic investment, some ingenuity and innovation, and then on the side there's a whole load of kind of rocket science, sort of fly to the moon, boil the ocean kind of projects that we've tried to avoid really.
Yeah, okay. There's a few things in there we might come back to. And Philippa, what's been your experience at Bolton?
So I think the same as my colleagues here, massive rollout of remote working, really to support the social distancing of people shielding, and obviously within back office services, we too, like Aid, had about 800 staff that we needed to get out within about 2 weeks, which is no mean feat from that point of view. But like you said, that is sort of a development of something we were already working on. But I think what's important to come back to on that is how, with especially around funding, because a lot of the funding we were given around obviously the laptops, but then there's the licenses. The licenses were free for a certain amount of time. So there's a lot of work we need to do now in the recovery part really of that bit, to understand actually keeping these things in place, but also really supporting with policy and working, and then reducing the estate and bringing the benefits out of obviously how we're doing the remote working across a massive obviously footprint. You've got to then get the benefits out of that, haven't you? So that's key, I think, going forward in recovery. But also at Bolton, we've done lots of other things. We've done supported the rollout of PACS radiology reporting within the homes for radiologists. Obviously they're quite a small workforce and very precious, so we've managed to get that working up and running in people's homes, so you can have instant reporting, and they've basically got the solutions at home. We've also developed an AI piece which has been supporting identifying COVID on basic x-rays, that's been led from Dr. Malik here, who's one of the associate CCIOs. But lots of things around how we use technology. So again, in Bolton, video consultation, so we've used Attend Anywhere that's been provided nationally, but we really stretched that technology. So we've used it in all the specialties, outpatients and inpatient, obviously ICU, but we also used Attend Anywhere to use in intensive care to contact families en masse, and that we could bring them into the waiting room and they could speak to their relatives either at end of life or in the recovery, which was really important. And that's been really profound in using that technology in that way. But also, as well as the hospital, we also had to support all the remote working for GP practices, and that is happening. And again, we had to do that within about a week, and that most of the GPs are actually practicing from home now to do that. So that is really significant. But then on top of that, there's all the elements around COVID and changes in with your EPR and what you need to change rapidly, which normally would take quite a long time, around clinical governance and clinical design committees, and how actually, if you get the right people with the command and control in the room, one about finances but also about major change, you can make some really good changes within your systems to support what we've needed to do. So like around oxygen levels within our observations solution. So lots of different things that are touching all aspects really.
Okay. So far, that's a lot of stuff. So clearly it's true. There's COVID-19 has driven the pace of change and innovation. My concern then, from the outside looking in, is this is a one-off. That as the epidemic stabilizes, its impact stabilizes, we understand a little more, and we go back to a normal but if somewhat different way of life. What's going to happen? What are the unintended consequences of the success in this situation? And how do we make them intended? So what I mean by that is sometimes when things happen and change, people's adoption of it, I've seen it before with other departments and in other sectors, when people start going round. IT in this moment in time is a reliable asset. In the future, it might be the department of no, because it's still your job to be professional, to think about things and its impact and its wider impact. How do we make advantage of this situation, which is a difficult thing to say, so I don't mean it to be flippant, but if we're going to keep the pace of change going in NHS as it needs to be, clearly, the NHS had a problem prior to this, didn't it? You know, the adoption, we know that actually, if the NHS is going to exist in the future and be able to deliver health and social care free at the point of delivery, it's got to adopt these digital strategies, and yet it's been incredibly difficult. And there's a history of, if I might say, sort of failed projects for all sorts of different reasons. How do we harness then what's happening currently and make it something that is just every day in the future? How do we take things that are happening now and just keep going, keep advancing, keep doing better for the NHS through the adoption of digital?
Shall I go?
Please.
You know, I mentioned, and we all know, don't we, that we've talked about lack of funding for what we do for a long time. Now we've had some funding. I think it's largely on us to demonstrate the value around that, and I think Philippa's mentioned that briefly in her introduction. But we really have to show that the things that we've achieved are providing genuine value if we're going to get future investment. And really, I think that for all of us, you know, there has to be some kind of a wash-up project on this that probably goes across areas in our organisations that we might not work with routinely. We're thinking about a project, for example, that encompasses HR and estates. It's all very well having people working at home in emergency situations, but they're not going to carry on taking over half the ground floor of their house for offices or whatever into the future, and that needs wrapping up in some proper terms and conditions and funding and all the rest of it. So we've got to provide that value. And then I think, you know, we've done a certain number of things whilst we're in incident management, and I don't think we should overlook the fact that once people do start to go back to work en masse, because, you know, they will, they're not all going to work at home forever. We're not seeing patients and outpatients at the moment, for example, who need to be seen. So people will have to come into buildings, and at that point we're going to be faced with new technology challenges, you know, so we're going to need yet more things that we haven't yet thought of. You know, for example, we can't have patients sitting in waiting rooms. How are we going to deal with that? You know, are they going to sit in the car park and be called in from there? There's a whole load of things we haven't done yet. So it's quite clear that, I mean, we're still getting a lot of requests for laptops, even though we've rolled out hundreds, you know. So there's a lot more to do, but I'll just come back to the value thing. We have to be able to demonstrate the value.
Yeah.
So I can reiterate that. So already we've got in our organisation a recovery group which meets weekly, and part of that recovery group is a golden thread group. A bit corny, I know, but that golden thread is HR, IT, and basically from that point of view, we're working with the divisions to look at how do we sustain this change. How do we develop that further, but also wrap around that governance that Age just talked around to make sure it's real and it's tangible and we're doing the benefits from that. And also from my governance structure, we're starting to lead on benefits realisation of all digital technology, because I think we've got all these toolboxes of items and solutions and things that we can give out. But actually it's about putting those together and making the changes. And for us here in Bolton, it's around that, the locality piece. And I think the one thing in COVID we've done, and I'm not sure whether Nikki and Adrian are the same, but there's definitely been more around a Bolton locality view, and that the costs are a Bolton locality, and now the savings need to be a Bolton locality, and actually really stretch some of those boundaries. So like if there's issues and we're looking at trying to prevent people coming in from nursing homes, and normally that wouldn't be something an acute or community necessarily deal with because it might be social care or local authority, but breaking those boundaries down and saying, well, actually we can put that solution in, and rather be precious that that's your job, let's just do it, because at the end of the day as a locality we'll all benefit from that. And I think those conversations since COVID are a lot more fluid, and I think we need to monopolise on them, but make sure, like Ed says, is just not go off and really go mad, but really look at what are the quick wins, and but also what are the longer term gains. So for instance, COVID again, there's discussions that people, as we have here and I'm sure elsewhere, are not attending A&E. So where are these people going? But is it because we've cracked the primary care, because people can actually get an appointment, albeit maybe virtual, that from that point of view, that backlog is then helping within A&E. Obviously there's going to be people that come, and we all know about the cancer rates and mental health element of that, but also what can we do differently to manage that in the long term? And is it actually that we need something more at the front door? And really, I know it sounds interesting, but can you have an appointment to come to A&E apart from if you come in an ambulance, and those sort of things, and what's happened that we can actually make what's a real benefit, and how can we take that forward? And I think those are the sort of things we need to really start looking at.
Yeah, but so I'll come to Nikki in a second, but further, whenever I've seen sort of major programs with regards to IT and digital delivery around the NHS, it seems to me there's two things have happened. One is that the policy is made the NHS, when it's made at a national level, it's the NHS is one organisation that speaks with one voice and procures in one way, which seems to be, I'm learning that's a big mistake. But secondly, it's national programs. Okay, it might be in devolved nations as well, but it's national programs, it's not local. So how do we take some of these lessons and learn? You're talking passionately about how you implement in the Bolton area, but one of the key things you've done there is pull in health and social care properly, and made those two things work. I've never seen that reflected in how people talk about IT and digital in the NHS. Is that can you see that, or is that not correct?
But we're all dealing with the same citizens, aren't they? They obviously, social care call them citizens, we call them patients. They're all the same individuals. There's only a certain amount of public services money. We all work in silos. It has to stop. I'm a clinician by background. You know, at the end of the day, it's the patient, it's those staff trying to work that. And if we look at the ICP and the integrated care teams, we're not helping them because of our organisational constraints and posturing in a way. That has to stop, and I think COVID has cut some of that, but it's how we keep the momentum, and I think that's down to us and other senior leaders in the organisations to really get and understand that and remember really why we're here. So for me, that's a really key point, and I think we've demonstrated some of that through COVID.
Yeah, okay. Nikki, how about you? What do you think in regards to how do we keep this momentum?
Yeah, and it should be easier in Cornwall. We only have one acute, we only have one mental health and community provider, and we only have one CCG, and it should be easy. However, I share the same concerns in terms of how moving forward and how we can manage to make that cost a shared system cost, because I don't know about you guys, but some of the requests that we're putting in or we have put in against the COVID spend have already come back as a no, you're going to have to find the money locally. So again, it comes back to an organisation cost pressure, and that is a concern going forward. So some of the really good quick wins like Teams and the Attend Anywhere platform that at the moment we haven't had to pay for, those costs are going to come back, and it's how we build that case as a system to keep those things going. Because you're right, Philippa, you know, just because the implementation's in the community setting, it doesn't mean it doesn't have an impact on the acute. And I certainly in Cornwall at the moment, although we might have a joined up story, the governance that's in place isn't quite as joined up. So we've still got separate financial committees to take one single business case through multiple organisations. And it's those kind of barriers I think we need to, as you say, as leaders, try and break down in the future.
Sure.
And I think I was just going to add, I think that the Teams and the N365 offering that are coming out is one of those success stories in terms of how Aid mentioned earlier about the influencers and how we've got the ears of people at the moment. It's a big figure to go to Office 365. Nobody wants to see it not happening now, so that's good, but it's still a big figure that the organisations have to find.
And how have those conversations with the people that you have to influence and all that in the wider governance structure and the governance context of the organisations within which you work, how have those conversations changed during this pandemic? How previously, I think people have been, well, in the private sector, I think there are some CEOs who still think that Y2K was the biggest con the IT department ever pulled over them, and are not quite sure whether that was value for money or it was the whole thing was a hoax. So how have those conversations changed in the pandemic? Have they changed? Have people seen IT more as trusted partner and change agent than perhaps previously, Nikki?
That's a good question. I think there's been so many different meetings going on. I couldn't answer that, to be honest. I feel like I've spent my life on Teams meetings. I think it's changing. I don't think it's changed. I think it is changing. Yeah, I don't think we were ever felt an untrusted partner, certainly not down here. But I think there's a recognition that maybe there's more reliance on the infrastructure, the boring stuff that Aid said that spent a lot of time deploying, that actually is essential to get right to make systems work. And I think one of the things we found down here, especially as a community trust spread across a wide geographic area, is the fact that the mobile suppliers came on board and said, you know what, NHS staff have some free mobile data. That helped us. That's helped us immensely. But the reliance on that isn't going to continue. So again, we need to work out how we're going to fund a change, because like Aid said, people will come back, but I think for community and mental health services, we will see a shift change in how they're going to run their services going forward.
Yeah, I guess again, that's Philippa's point about local knowledge, if you like, that actually that mobile data for the teams operating down in Cornwall there has such a massive impact that you might not have noticed. So if your experience was only providing stuff in Birmingham, that might not have been the obvious win for Cornwall. So that's quite interesting. Aid, what do you think about trust with regards to what it is you're saying now to governance and people are making some of those decisions?
Well, I think from the top to bottom of the organisation, really, the conversations are now different, because you've got just a much more receptive audience. It doesn't matter who you're talking to, actually. And I'm sure that I'm now sitting in on things, getting invited to things that I possibly wouldn't have even been invited to before, because people are now saying, oh, what's the IT impact of this? And they might not have even asked that question before. You know, I'd be the only one in the room asking that question. So that's a good thing. I think, you know, everyone from the chief financial officer through the COO and the chief exec, etc. The chairman loves chairing trust board, actually, with using Teams. So I've got a whole bunch of people who are surprised, but I think that overlooks the fact that we've got a huge issue with digital literacy across the workforce, actually.
Yeah.
And that is something. Sorry, I don't think it's discriminative. It's like the virus doesn't discriminate. So, and I was talking to someone actually about this the other day, and I think that to a certain extent now, digital literacy is a little bit like, you know, real literacy, as in reading and writing was maybe 30 years ago, where people used to hide, and then there was a campaign to uncover that and make it less of a stigma and those kind of things. And you know, by all accounts, that's been successful. I think we do have a situation where people who are not digitally literate, or to a certain extent hiding, or have been hiding, and now we've got to do something about that, really. You know, we're spending too long on the phone sorting out people's home broadband issues or connecting their thing to their other thing. You know, these things, that should just be business as usual for anyone in their normal life. And we hear about it all the time, don't we? Oh, well, everyone does their banking on their phone and blah, blah, blah. Actually, they don't, you know. Yeah. There's a lot of people that don't. And there's a lot of people that don't know how to plug one cable into a computer or whatever. They think that's, you know, techie or something.
Yeah.
And I just like that. Sorry, just add there that we agree, but I've also seen the opposite, where we've seen a lot of people who before would have been quite needy doing a lot of self-help or peer help. So we've had some really good stories.
I wouldn't want you to get me wrong and say everyone's been rubbish. They haven't. They've been amazing. You know, we've got, as I said, we've got thousands of people working at home. But it's like that thing that people talk about, isn't it? Where, you know, the 5 or 10% of your people will take up 90% of your time.
Yes. And if we are ever to move to some of the the picture I was trying to paint, where we make, and I think Philip has mentioned it already, you know, greater use of AI in clinical practice, if we make greater use of some of the advances in computing and digital, we've got to be able to do what I would call the keeping the lights on stuff, which is quite a lot of what we've discussed up to this point has been around that sort of infrastructure support, you know, allowing people to do their jobs. And what the promise of AI is about huge step forwards and advances in what we're able to do in health and social care, which seems to me a completely different paradigm. I'm also reminded that GDS, when I was working with Government Digital Service, when talking about the average reading age in the UK for the whole population is 12 years old. And that wasn't a long time ago, that was last year, or the year before, sorry. But it was, you know, my point is, the same is probably true of digital literacy. There are super users who when they're brilliant, form their own little cluster and other people help, and they can help and broaden out. But really, there's still a lot of digital knowledge which isn't quite as advanced as we might think to be, especially I think in leadership. And again, I'm not trying to cast any dispersions on people's great intention, but people who are leaders of lots of organizations have come up through different routes. And I'm wondering again, Philippa, how you're helping not only to persuade those decision makers, but almost help educate, because we can sell a promise in IT really, really well, but people have been burnt by that in the past. So how are you finding that sort of communication and cultural shift that's driven some of these developments?
So it's very much that, and interestingly enough, I've just submitted my dissertation for my health information masters on that, and it's been around leadership and culture with technology adjustment and change, really, and it's been really interesting. And I think one of the things from my point of view, and that's I'm sure with my peers here, is about saying it's about the authenticity and the user-centered design. So for me, it's about absolutely making sure those staff, those patients are involved, and that we are listening to what they say and guiding them. You know, it's not just a shiny new piece of kit. Actually, what is the problem? And then we have to look at that. That's where I think the authenticity comes, and I don't think that's necessary for me. That's anybody that is understanding of the problem of practice that we've got. So from that point of view, I think it's good if you work. I've got really good support clinicians here, CNIO, a whole team of CCIOs, obviously links with the GPs, facilitators. They're all key individuals that are doing that piece of work to be that facilitator between tech and practice, which is so important. But I wanted also to come back from the last bit and talk about, you know, the changes in culture and leadership. If we look at Cotter and the 8 steps of changes, that's really key, because that talks about the big opportunity. And I know that sounds really awful that COVID is a big opportunity, but it has been. And when you look at those 8 steps of change and how you get the workforce on board and they become involved, and you've all got the vision and what you're trying to do, which is often under crisis, you can really bring that workforce forward, because you've all got the same values and the beliefs about what you're trying to achieve. So I think that's really important. And we look at other things, and how we do it is to go back to those sort of methodologies, to remember that, one, we need to have a vision. They need to be embracing it and engaging, but also part of it for you to be successful. And if you're not, then we're not going to do it. And that's the same on a locality piece. When I talk about coming back to the citizen, that's so key. And I think if you keep telling those stories and those understands the problem of practice, how can we not work together? But culturally, as Ed says, we've got a different workforce to work with. I was looking to see if there was an age difference. There isn't. It's, you know, been really profound in my analysis to look at, you know, what makes the differences. And I have to say here, one of the biggest difference to engagement has been higher levels of temporary staff. You know, and there's certain things that we can absolutely look at if we roll out and there's an area of high turnover or lots of staff with bank and agency. I know now that they're going to need far more investment than another ward that hasn't, and that's the sort of things that we really need to pick out and understand the nuances when we've got a massive organisation of how we treat different services differently.
Okay, so I was interested, one of the things you said in there was you talked about that the motivation match between all the teams, especially in this global pandemic, all hands to the pump, everyone is fully committed. But I would always consider that to be the NHS day to day. You know, what the NHS is there to achieve is the best outcome for the patient, and everyone is motivated towards the outcome. Why has it taken a pandemic for CIOs to be taken as seriously as they should have been right from 5 years ago, 10 years ago? And how do we, in your estimation, keep that going? Why were we ignored prior to this? Grand we on my part there, I'm not including myself. And now it's being adopted. What can we, is that true, and how do we keep that going?
That's quite simple, really, isn't it? There's only one pie, isn't there? You know,
Yeah.
I mean, our chief financial officer is, you know, very supportive of digital, and you sit in the room at our digital board and he said, I know you lot. He said, you all love this stuff and you love the strategy. But he said, then I'll go to an estates meeting and you'll be telling me the windows are all falling out of the West Wing. Where am I going to put the money? It just so happens that at the moment, sorting out COVID is more important than sticking new windows in the West Wing or whatever.
Yeah. So to your point,
people will revert to type fairly quickly when winter's drawing in and there's draft coming through the windows in the West Wing. You know, that's why it's so important you prove value right now. You know, make hay while the sun shines and all that.
Yes, absolutely. And is that message getting through? Do you think people are understanding the value of what digital is delivering?
Well, yeah, I mean, I think people definitely valuing it. But of course, I think people have got short memories, unfortunately. That's humans, isn't it?
Yeah, absolutely. Nikki, do you see that too? Because there's benefits in what you've been delivering, but the realization of those benefits surely aren't going to stop. You've spoken about, you know, it's going to be a big price to move everyone onto and keep everyone on 365, for example. The pie is being sliced and diced to deal with the windows in the West Wing. I guess there's going to have to be a larger pie, isn't there? There's no other way around it.
Well, we're heading into a recession, aren't we? That's going to be difficult.
Yeah, there's always a smaller pie, never a larger one.
Yeah.
Absolutely, and I guess that's where some of those central negotiations around procurement, I think we all, and we touched on it earlier in terms of sort of the removing some of the barriers and the bureaucracy around how long it takes to do things, and one of those is procurement. We all, as all separate organisations, go through long and protracted procurement process, probably to all end up with the same or a small number of systems, and there's something I think in going forward in treating us as a whole NHS to get the best price for a suite of systems. So some of the frameworks that are already there obviously allow us to do that, but there's still a lot of local negotiation, and we've been waiting a long time for that Office 365 negotiation to come forward, and it did feel like COVID kind of put a bit more pressure on that. I don't know how it feels for you guys, but yeah, it's a concern going forward.
Yeah, and so I think we're in agreement. Clapping is great to show support, but professionals need to be funded properly, right? So that's just all we need to say about that one. I'd like us to go around and talk about something that I like to talk about, which is hope. And what is that? What is your hope as a result of COVID-19, which to the greatest part has been tragic? What is your hope for the future with regards to specifically the NHS and its and digital adoption? What is something that you're aiming at, so it's not completely a moonshot, but what is your hope as a result of the things that you've seen that you might see in the next 6 months, year, 5 years? So Nikki, if we could start with you.
I suppose, and it's something that I've seen in our teams, our digital teams in Cornwall, I guess, is that can-do attitude, and that before, I think one of us touched on it about the department of no, and I think my hope for the future is that we get rid of that, so that we're not seen as the department of no, but the department of trust and can do. I think also around that digital embracement and making sure that we don't use all the good stuff we've done. Not all of it's been perfect, and I think we can improve, but there's a lot of good stuff that we've done in a really short space of time, and it would be a real shame to see that go backwards. So the video appointments is one thing that I'm really keen that we sustain going forward, and operationally get our teams to look at how they then put that into their different service pathways.
Yeah, I guess that's something that we can measure as well, so it's quite rather than being flawed. Philippa,
we won't have so many buildings to have the drafty windows, Aid.
Yes. Philippa, how about you?
Certainly got them in Bolton. Yeah, I think like Nikki said, really for me it's around the changes in the pathways, and I think that will demonstrate the change on a longer piece. So for me, my hope is, as I've sort of discussed previously, around that locality piece and then the STP piece, how we can really make sure that those pathways are sufficient and effective. And when I mean that, I mean, so like for myself, I don't want to go to the GPs. My GP is 40 miles away from work. You know, the stuff that I've had in the last couple of weeks has been awesome. Those are the things that I expect as a citizen, and I want to be able to offer them. And sort of one version of the truth, one place where you can get your information. I know it sounds a bit altruistic, but actually with investment we can get there quite simply. But the other thing for me is the hope is that, like Aid said, we've absolutely doubled some of our infrastructure, and we need to have a service who then won't become the no service, that can provide that stability and the new technology. So I think from now what I need to look at is about rebalancing. What does that team look like to the organisation, and say that actually over these 6 weeks it's absolutely changed the way that my teams work. And like you say, I can't go and sort somebody's broadband at home, that's a virgin problem, etc, etc. But we need to flex and change and be agile, and that comes at restructuring, looking at costs. So I think from my point of view, the hope is that I need to work with my executives to make sure our IT services fit for purpose for business as usual, but then also to be agile to be able to do some of these new technologies. And that's key, because if not, we're going to just go back to being an overburdened service that's going to be saying no again.
And has thank you, Philip, that's really good. Has the balance of your team changed? The dynamic between whether you've got how many people you've got working in different teams in different areas, has that been something that you've seen?
So yeah, so for instance, obviously when we were looking at when COVID hit and we were looking about the remote working, we were also in the middle of a go live for community 0 to 19 services electronic patient record, which was really quite tricky. But then also we needed to deliver change and some training. So we had to use our training department more with the technical team, and then I had other people learning about how to get the laptops up and ready. And so there was a lot of skill review. And although in the organisation I didn't redeploy any of my staff within the organisation, which happened in other areas, I redeployed them within my own services to provide the needs of where I was, which actually I think has broken down some of the silos of informatics. So the other thing from that is, how do I monopolise, keep going on that, and that we all benefit from really not having those silos just in IT and informatics, CPR, code and BI. I think it's brought that together.
Okay. And Aid, I know you're famous for a hopeful message. What's your hope for the future? What do you see coming out of this?
Well, I think stickability, really. That's what I'd hope for. You know, I was having a chat with our COO the other week, and jokingly, you know, I wouldn't want to be flippant about this crisis, as you've already said, Adam, but you know, somewhat jokingly, I said we could do with this going on for a few more months, because if it stops now, then everyone's just going to go back to doing what they were doing, you know, because they'll revert to type very quickly. And you know, when you think, another thing I've said recently is, when you look at the long-term plan for the NHS, its aspiration, it's set a very aspirational target to do 30% of appointments in a non-face-to-face way, and now that all seems like a bit of a joke, really. You know, because actually, although that was a stretch target, I think we've all exceeded that, or at least I'd like to think we have. We haven't really done all the numbers yet. And then beyond that, I think, you know, I mean, truly digital first, you know, that people are thinking digital first, and that their thought processes don't automatically take them to designing another paper form, which is where they've always tended to go. And I think you've really achieved success when you've put the technology in the hands of people who then go off and start doing things with it that you hadn't even thought that they were going to do. You know, like we've got our ED people, they came to us last week and said, look at this, they've got iPads down there running Teams, and they're doing senior consultant review remotely, which not only means that those senior people don't necessarily have to get all PPE'd up to go and review that case, which is great because they can carry on and do it from wherever they are quickly, but we're getting them doing like senior review from home now as well. And like the radiologists, well, they're all working at home now, so, and they're not restricted, and because we're in an imaging network, they can report right across the region, and people are starting to do things with the technology where they've taken it in their own hands and they're doing things with it. So I guess my hope would be, yeah, stickability, digital first, and more of that, really.
Yeah, well, the impact, listening to you all this afternoon, and some of the other evidence, of course, I've been hearing has been really quite profound. I did say that I said it'd be done in 25 minutes. I did say we'd have questions. I'm not sure. I think I've got Simon or Julie are also on the line. I don't know if we've had any questions from anyone who's listening in. Hello, Julie.
You've had a lot of questions. Hi. So we can't ask all of them because we have had quite an inundation of questions. But one thing that I think is probably quite interesting, and it probably plays into a conversation I think Philippa we've spoken about. From the outside, the NHS is extremely complex and confusing. Do you see any restructuring post-lockdown in order to simplify the organisation? Philippa, we talked about commissioning. Do the rest of you sort of see there is a need for that to change as well? Philippa, do you want to pick that one up?
Oh,
I thought you were asking them. That's fine. So yes. So I think with the restructure, and again around your locality. I think this is the time now to really look at how you can demonstrate en masse and who can be the provider of those services to make sure. So like in the locality, we're all pushing data around. We should have one version of truth. It's the hub and spoke. There's those sort of things that I think myself as a CIO should be saying to our locality around those system savings, and say we don't need the duplication, but actually we do need one version of truth. We should be coming at this together. How can we look at our services and bring them together to get the benefits of that, to really form that ICP and in a formal way. But those are the conversations that are starting now, and I believe they're key, and that's where the restructure will come. But not only that restructure, more externally looking at your organisations, but even internally, and to really break down those silos. And for me, it's like training, looking right across the whole piece, from the technology piece going into that digital maturity and by the elbow. For me, that needs all refreshing, and that's what I want to look at within my internal structure, restructure as well, and really possibly turn it on its head, but in a good way.
Ada or Nikki, do you have comments on that, about whether this is going to drive a sort of a new version of what staffing looks like?
Yeah. So, I mean, I guess there is a tendency amongst people to try and solve some of these big problems all of a sudden, because the emphasis is on, we can solve things. But, some of these things are very, very embedded. They're 20-year-old problems, aren't they? And, you're not going to solve 20-year-old problems just because you've had a bout of COVID in the country. But there are some things that we're going to have to do quite clearly. I think one of them is going to be around how organisations help each other, and we're talking about a concept of mutual aid. Where is the capacity? How can we get back on top of things like our performance against 18 weeks and that kind of thing will have gone right out the window through this, and as I mentioned, there will be some people, you can't treat everyone on the end of a phone. So how are we going to get back on top of that? And we are going to have to do some pretty ingenious interoperability, I think, to be able to start managing some of these cases between organizations where, traditionally the pathways that we're involved in are pretty linear, really. You land in, let's say, a hospital for outpatients. If you need an operation, 90% of the time you're going to have that operation in that hospital where you have the outpatient appointments. Some things are outsourced, but that's usually the case. So we're going to have to do some pretty ingenious, as I say, things, and I think that is going to require some different governance structures in order to enact it.
Sure. Okay.
Just to add to that, I guess the bit that has come to the fore down here in Cornwall is the importance of care homes, and how probably before, although we had a plan for a Cornwall and Isles and Scilly partnership, I don't think care homes were very prominent in that, and how we support them and can support them going forward in different ways of working. So traditionally very IT poor environments don't have connectivity or have limited connectivity, and providing services into care homes has been a real challenge down here during this crisis. So I think it's sort of thinking wider than what we would recognise as traditional NHS organisations. Yes, we can work closely together, but it's wider than that.
Yeah, I mean, there's charities and all sorts as well eventually that you get into, as well as what else is happening with the councils. Julie, what else?
Yeah, so one other question of interest. If you could choose one example that you would highlight as having had the most impact on improvement in your trust over this period, what would it be? And I guess that's for each of you, really.
Oh, okay, first for us it would have been the video appointments, that's in mental health particularly, and we've got some really good examples of, in particularly in our young people services, with clients who wouldn't even come to site but have engaged with the video sessions, and that's been really impactful.
Yeah, I guess for me, video, across the board. Teams has been a huge impact actually as well. Not just, we use Attend Anywhere for patient consults, but Teams has been huge. We've went from 100 users or something up to over 5,000 users in a couple of weeks. So huge
Wow.
sort of growth in that. Integration of results into Teams as well. That's been a very interesting project. So we've got channels within Teams where COVID results, for example, appear in, but not just COVID results, other things that are urgent, and that impacts the ability to manage patient flows in the hospital. And I mentioned the outpatients earlier as well, the fact that we've been able to keep on top of the outpatients areas by doing electronic triage rather than descending in what I would call like a chaos of spreadsheets, which would be the default. I'm really pleased with the fact that the team have done that.
Thank you.
I would just,
sorry, I'm just going to say I'm going to nick chaos of spreadsheets in the same way I'm going to steal that digital literacy does not discriminate. But anyway, Philippa, over to you. What else have you seen?
I think mine's pretty much the same. I think obviously seeing it across primary care and secondary care and community, I think that's been one of the wins, that we've got it across the pathway, but also using some of that video consultation in the use of end of life, I think has been really key. But also I think from our point of view is that partnership working. So in Bolton we were fortuitous that we managed to keep our cancer operations going at the local private hospital with support from the CCG. And I think those are the sort of conversations that we continue, now as we look at red and green COVID areas, if we're going to have this for the next 2 years, those are the sort of things that we're going to have to keep. And those conversations are being had, but likewise how we provide our electronic patient record and all our results and reporting, within the private hospital, so people can manage safely, and documenting the notes is really important. And we've done that at speed. And I suppose for me, that's quite profound, and that's what we need to try and keep going.
Okay, thank you.
Thanks, Philippa.
Julie, have you got a last quick question?
Yeah, I think this one you can probably all have a view on. What does the panel think the legacy? What do the panel think the legacy will have on data quality across their systems, and what will the impact be on data management practice? So that's obviously quite topical. Aid, what do you think?
Well, once again, I like to be optimistic, so I think that will be a positive impact on data quality. The fact is that people are now relying on the digital systems more than they were before this, and there's no better driver for data quality and digital systems than people relying on your data.
Yeah,
Very true.
agreed. Part of the lesson learned here that we've just done last week, I have to say informatics has come out really positive, and that's been around the speed acting of providing data, providing that on the portal so we can see around COVID and the different information around PPE on a daily basis for the command and control. But also, like Ed says about, anecdotally in A&E, when you're using PPE, that everything's there at your fingertips. Whereas sometimes that culture and that engagement has been difficult because we're quite newly deployed in EPR. But I think this has absolutely demonstrated those benefits, as Ed said, and it's made them hungry to develop more. So actually putting more pressure on us, but in a really positive way, because they can now come to say, I want this, because I can really see that will be beneficial. So it's how we monopolise on that.
Sure. And Nikki?
Yeah, I agree with the other two. In terms of the focus on the data, we've been got through some data quality issues that we had previously around bed management, seem to have been resolved now, now that the data's been looked at, which is great. But I think also it's made some of the services question how much data they actually need to capture. I think we're going to see a rationalisation of what actually is necessary. So across our mental health community services, there seems to be a lot of assessment forms that are essential, but perhaps aren't essential, and actually it will cut down the amount of time. We get better quality of data, having less data in a way.
yeah, more timely, but more usable. And yeah, absolutely. That's a very important lesson. I think we're spot on the hour, I think. So thank you, Julie, for those questions, and thanks to everyone who's been listening. I'm sure there are more questions as well that came through we didn't have a chance to get to, but I would just like to thank Philippa, Nikki and Aid for their time this afternoon and to share their experiences, because it's been incredibly interesting, very insightful. As I said, we're very grateful to what the NHS is trying to achieve, but it's what is in the art of the possible for the future that is particularly exciting with what digital could do. Thank you very much for your time. Thank you everyone who's been listening. Thank you.
Thank you.
Thanks.
Bye.
Lovely to see you.